Thank you and welcome. Clearly you can see we believe in strength in numbers. There's quite a few speakers. I think we hold the record for this conference. So I'll keep it pretty short. We were here last year. We talked a lot about the preliminary data. The people that are going to follow me are going to talk much more in depth about that. But just to give you a little bit of history as to how we got here and really how the conference started. In 2010, we started Quest Nutrition, which is essentially a food company. We make everything from protein bars to frozen ketogenic meals. And we had pretty meteoric growth. In 2014, we were named the second fastest growing company in the US by Inc. magazine. And that success really allowed us to parlay that into pursuing some of our deeper passions. And I've been interested in the Warburg effect since about 2007. And 3.5 years ago, Dominic D'Agostino, who I know most of you know, and a gentleman named Peter Attia came to our office, and they really schooled us on ketones, ketogenic diets, ketone metabolism. And you know, I can't think of too many times in my life where in one day my life took a complete 90-degree turn. And one of the things we wanted to do was we wanted to contribute to this in some way, and most of us weren't scientists, and we said, how can we do this? And what we did know about is nutrition, and we know that the biggest problem with nutritional research is compliance. Self-reported studies create a lot of problems, and we knew that the gold standard for compliance was canines. And Dominic said at the time, if you're going to do something with canines and ketogenic diets, you're going to want to work with this guy named Dr. Q, who is here in the audience with Signature Health. And we teamed up and had this crazy idea to basically start a 53-acre ranch in Texas. We'd feed dogs that we found from kill shelters. We'd feed them ketogenic diets. We would take their blood ketones and blood glucose, like many of us do, a few times a day. And we were going to have perfect compliance. And we'll talk a lot more about the data. Shannon's going to follow me in just a little bit and talk about that. But KPS was kind of a big moment for us. We've been running, I think, for just a little over 2 years. The data that we got out of that got us really excited. That led to the founding of Epigenix Foundation. And really, Epigenix is kind of an answer to the whole genomic problem. If you look at what's happened over the last 20 years, a lot of investment, a lot of time and energy has gone into the genomic side. And we thought that the epigenetic side is equally, or to be quite frank, more important. So that's really where we focused our energy. And one of the problems is some of the most profound interventions, some of the most profound ideas never get funding simply because there's no proprietary molecule, there's no pot of gold at the end of the rainbow. So that is the kind of stuff that we tend to be interested in. It's got to be A, very powerful, but B, it doesn't make us afraid if there's really no endpoint, in terms of financially. The things we focus on really, heavy focus on cancer, diabetes, cardiovascular disease, et cetera. We've got essentially these people here that are going to follow me and talk about experience in canines. Will be Shannon Kesl, who comes out of Dominic's laboratory as well. And then Dr. Jethro, who is going to talk about brain cancer and ketogenic diet, some really interesting collaboration that we've been doing together in LA. Isabella Sledge is going to be talking about some of our efforts in early detection, which we think are going to become more and more important in terms of actually being able to move the ball. And then Dr. John Sledge is going to actually be talking about the future and what we see going forth in terms of where we're going to focus our efforts. And with that.
Alrighty. So as Ron mentioned, the Keto Pet Sanctuary is a 53-acre facility in Georgetown, Texas. It's about an hour north of Austin. It is the Cadillac of sanctuaries for dogs. If I was a dog, I would really want to go there. They have treadmills, couches, everybody has their own bed, they have gourmet food made for them twice daily, and of course they get plenty of exercise and snuggles like Arnold, who is here. That makes me hold him like a baby. Our therapeutic methods, we had, as he mentioned, these are all shelter dogs. We did have a couple own dogs, but they were predominantly shelter dogs. So we searched the shelters of Texas, and our inclusion and exclusion criteria are the following. They had to have a confirmed neoplasia by pathological or cytology. They had to have a PET CT positive tumor. They had to have a measurable malignancy greater than 1 centimeter. And then if they had brain metastases, significant comorbidities, malnutrition, or a life expectancy less than 12 weeks, they were not entered into the program, or an absence of the gallbladder. I want to emphasize that every single one of these dogs got standard of care, whether it is veterinary or oncological. We worked very diligently with our vet and vet oncologists to determine the best course of study and therapy for these dogs. So we have used surgery, chemo, radiation, and or the combination thereof to ensure the health of these animals. All of them were fed a 2-to-1 or in between a 2-to-1 and 4-to-1 ketogenic diet. It was calorically and ketogenically matched for the dog's needs. The diet composition came from predominantly 70-30 raw beef or raw ground chicken breast. We also had several fat sources, which dogs can be like children, so some of them like coconut milk better than they like butter. And we also included some low-carb fibrous veggies to like cabbage, green beans, broccoli, and Brussels sprouts. And we balanced the diet with prebiotics, probiotics, some omega essential oils, and the vitamins and minerals. All their weights were measured 3 times a week, and again, their caloric intake was adjusted as needed to ensure optimal body composition. There were a lot of these dogs that came extremely obese, so we also helped them lose weight as well. And their blood glucose and blood ketone levels were measured 6 times a week. In concert with the ketogenic diet, we also provided hyperbaric oxygen therapy at 2 to 2.2 ATM, with hatch time being 90 minutes, and they were at depth for 60. We did this for alternating days of 3 days of therapy, 1 day off, 2 days of therapy, and 1 day off for 120 days. And as I said, they were also had metabolic conditioning or exercise, and all dogs were exercised 1 to 2 times a day for 20 or 30 minutes, depending on their physical limitations. There were some dogs that were completely arthritic and that they couldn't really exercise that much, but we exercised to the best of their ability. We are the only facility that has a canine PET CT in the United States, and the dogs we used a GE Discovery 16-slice PET CT scan, and the dogs received PET scans on day 0, 60, and day 120 of the study. So just a little bit more about the dogs. The dogs we didn't just grab a bunch of beagles and this is actual research project. These are actual dogs that range from 4 to 14 years old. They have a bunch of comorbidities. They were shelter dogs. We don't know their history. We have no idea what happened to them earlier in life. And we did have a nice ratio of mostly male to female. It was actually really weird that way that it ended up being 50% of each. And we have sizes of dogs from Chihuahuas to Boxers to American Bulldogs. So you name it, we have that type of dog. We have also seen 8 different types of cancer. Some dogs actually had more than 1 type of cancer. Arnold, that I showed you earlier, actually came in with 4 types of cancer. So we've seen anal gland adenoma, we've seen hemangiosarcomas, lymphomas, mast cell, mixed mammary tumors, melanoma, and even squamous cell carcinoma. So it's really all over the board, and we really wanted to see what we could do, just not in 1 type of cancer and also just in not 1 type of dog. It's really a therapy to see how we could help all kinds of animals, and especially dogs. So in measuring their blood glucose and blood ketones, with the help of Dr. Lauren Nations, in which some of you saw earlier yesterday, we were able to see some control diets and looked at blood glucose of dogs that were fed kibble, wet food, and even a mixture. And as you can see, their averages are around high 80s, low 90s, where our average that we received on the 120-day therapy was 63. So we could already show that we could decrease blood glucose on this diet in these dogs. However, it was a little bit harder to increase their blood ketones. We were really happy to see if their blood glucose were above 3, but we were overall on the 120 days, we were able to get an average blood ketone of 0.7 millimolar for the dogs. So the big question is, what's happened since then? And we actually had 40 dogs entered into the program. Of that, 22 of the dogs finished the program all through the 120 days. We did have 18 that didn't finish the program. 6 of those did pass away from cancer that they didn't make it through. 2 of those died from a non-cancer incident, like getting eaten or getting bit by a brown recluse spider. And then we also had 10 that didn't get all 3 scans, so we didn't want to include those in our completing the program because for some reason or another the scan didn't want to work that day or other various reasons, and that way we didn't get to complete their story. So of the 22 dogs that did finish the program, 8 of them at 120 days had no evidence of disease. 4 of them had decreased evidence of disease, and 5 of them had stable evidence of disease. So that's a 43% a positive effect on these dogs of just with diet and hyperbaric oxygen and their standard of care. And we had 5 dogs that had increased evidence of disease. However, with these types of cancers, we have no idea that if it's slowing the cancer down. So even though it's increasing, it could be increasing slowly. So then I also did a follow-up of these 22 dogs as of January 1st, and we now have 11 of those dogs that are cancer-free. We still have 4 that have active cancer. We have 4 that did end up passing away of cancer, but I will get into that a little bit in the next slide. And then we have that 3 that passed away not because of cancer. And this is Dora. She's a ham. So of those 22 that completed the 120-day therapy, we had 8 of them that are now surpassing their prognosis that were determined by a vet oncologist pathologist or a veterinary oncologist. And of those 4 that passed away of cancer, only 1 of them didn't make their prognosis. The other 3, they passed away of cancer, but they were long past their prognosis. The only one that didn't make it was Conan, who was actually one of our own dogs, and he was in remission after his 120 days, so the parent took him home. But the parent decided not to keep him on the diet. So his cancer was back in 2 months, and he was dead in 4. So overall, I think we are doing a fabulous job. I think there's a lot more that we need to learn with these dogs, especially with the different types of cancer and how they respond. Overall, we have a very positive effect on multiple types of cancer, and I'm really excited. And I mean, my job is to do science and snuggle on dogs all day, so I can't really complain. So with that, we did transition into some human patients. We were really excited by some of those results. So we started with a pilot study in Baton Rouge, just because all of you have done clinical studies and been able to get your patients to do these things, but we wanted to see it for ourselves. So we just wanted to see how compliant we could get the ladies, and we also wanted to see if what's all this is all about. So we did a 6-week study in Baton Rouge, and we put them on 3 weeks we did 4-to-1, and then on 2 weeks we did 2-to-1. And just like the dogs, we realized that no matter if we did a 4-to-1 or a 2-to-1, we were able to see similar blood glucose and blood ketone levels, so we made it less restrictive for them. They were also had metabolic conditioning, and they were told to test their blood glucose and blood ketones twice daily, as well as check in with Victoria, and she can crack the whip on them if they weren't complying. And also they had a health coach, and they had group meetings as well. So what we saw from that was they were compliant. We had an average of 1.4 millimolar glucose or ketone, and we were able to decrease the A1C by 14% as well. So from there, since we saw that this is feasible, this is something we could do, we partnered with Cedars-Sinai and Jethro, and he will be taking you through that story.
Good afternoon, everybody. It's truly an honor to be here today, and this conference has been great. I've learned so much from all the exciting research that's been going on. As Dr. Kesl mentioned, I am a neuro-oncologist at Cedars-Sinai in Los Angeles. They keep me in that glass building over there. My journey to all of this began when actually one of my patients, a gentleman who had recently been diagnosed with glioblastoma and is actually in the audience here today, expressed interest in adopting a ketogenic diet. And so I said, okay, I'll refer you over to one of the dietitians in our cancer center, LJ Fitzpatrick. And I was half expecting LJ to kind of give the line of, well, this diet has never really been studied in glioblastoma patients. It's not necessarily a well-balanced diet. There may be some issues doing this diet with chemotherapy and radiation. But instead, LJ said, okay, let's do it. LJ is a very sociable and pleasant person, which is good because one day she was out at dinner and she met somebody who was associated with the Epigenix Foundation. And so we all got together and met up, and that is our origin story. So this slide is familiar to anybody who treats brain tumor patients. This is the Kaplan-Meier survival curve that comes from the seminal phase 3 trial published in the New England Journal in 2005. that established our current standard of care of radiation plus temozolomide chemotherapy. Now, from an oncologist perspective, this is truly a big breakthrough. You can see how those two survival curves, the red of radiation therapy alone and the blue with radiation with the chemotherapy, they do splay out. There is a significant difference between those groups. Without chemotherapy, you have virtually no patients who are living 3 years with the diagnosis of glioblastoma. And with chemotherapy, you have a subset of patients who make it that long. So to an oncologist, this is a big breakthrough. However, from a patient's perspective, I think you would look at that survival curve, even that good blue one, and say, wow, look at how survival drops off at 6 months, 12 months, 18 months. That still leaves a lot of room for improvement. That still leaves a lot of room for patients to say, you know what else is out there? What else can I do? What else is under my control? And so because of this interest, this meeting that we had, we put together what I would say is one of the most unique meetings I've ever been a part of. I started asking a lot of my patients, are you interested potentially in this diet? And the response I got was tremendous. There was incredible interest among the patient population. And so we put together a meeting with a random assortment of patients from all different backgrounds, their families. I was there, LJ was there, other dietitians were there. We had all the Epigenix folks as well. We sat down around a big table. We talked about the evidence and the lack of evidence for the ketogenic diet for patients with cancer. And then we said to them, hey, if you're interested in adopting this diet, we will support you. We will individually tailor a meal plan. We will talk to you every single day to make sure that things are going well. We will give you all the food and snacks that you want. We will give you the monitors and the monitoring strips so that we can closely track your weight, your blood ketones, your blood glucose. We will do all of these things if you are interested. And the response, again, has really been fantastic. Again, to be very clear, this is not a formal clinical trial. This is a mixed assortment of patients coming from mixed backgrounds. But ultimately what we put together is basically a cohort of patients who were interested in moving forward with this. And we went forward with a 120-day calorie-controlled ketogenic diet. So of the patients that started from this meeting and moved forward through this whole 120-day program, there are other patients who've since forth been also compliant with the ketogenic diet. But of the patients that started with this program, there are 6 that we have basically pretty solid data on. This is the background for the 6 patients. Again, you can see the background is mixed. We have 3 patients with recurrent glioblastoma, 1 patient with newly diagnosed glioblastoma, 1 patient who was newly diagnosed with a low-grade glioma, an oligodendroglioma, and 1 woman who was diagnosed with a low-grade spinal cord astrocytoma that had progressed through therapy. Some with concurrent treatment as well, so again, really a diverse background of patients. Here are some results. I'm not going to belabor the results too much because, again, this was not a clinical trial. This is just basically a bunch of patients that we got together who adopted this dietary and nutritional intervention. Patients did lose weight on this trial. That was something that was significant. The point of this slide, I would say, is just look how much data we collected. We were able to, one of the big questions was, in this population of patients, some patients who, may be on the sicker side, are you going to be able to obtain good compliance with regards to data collection? Are patients going to be willing to spend their time checking blood sugar, checking blood ketone levels? And yes, absolutely, we got a whole ton of data even out of this limited experience. These numbers just summarize the compliance. We have good compliance basically across the board, both with the glucose and ketone monitoring, about in the 80% range. You could argue, of course, again, this is maybe a little bit of a cherry-picked population of patients, a very motivated group of patients. On the other hand, I would argue also that, well, this wasn't even a clinical trial. We didn't even kind of hold their feet to the fire to really check this. This was really from their own motivation that they went forward and did all of this monitoring for us to collect this data. Let's look at some scans. So first patient, this is a patient with recurrent left parietal glioblastoma, a 27-year-old philosophy major. Actually, he was an aspiring physician when he got diagnosed. He was hoping to go to medical school. Before the ketogenic diet, you can see that there's that enhancement along the anterior edge of that left parietal resection cavity. While on the ketogenic diet, on his next MRI scan, you can see that enhancement is a lot less. Now, to be sure, there are a lot of potential mitigating factors here. Maybe the timing of the contrast injection is a little bit different between one scan and the other. Maybe the concomitant therapy, including things like bevacizumab, which he was on actually prior to starting the ketogenic diet. But still, maybe that had something to do with it as well. Maybe the decreased enhancement that we see here, it's not necessarily an anti-tumor response, it could be, but maybe it just has something more to do with vasoconstriction and less leaky blood vessels, so less contrast enhancement. So again, I can't point to this and definitively say he had an anti-tumor response, but certainly you can see that there's a difference from one scan to the other. Now, on the other hand, you can look at this sequence. So this sequence is a sequence on MRI called FLAIR. It's nonspecific, meaning that abnormal stuff of all types shows up as hyperintense or bright on FLAIR imaging. So what you see as bright here is a combination of tumor, infiltrative tumor, cerebral edema, radiation treatment effect, all of those sorts of things. And if you kind of squint and look back from one to the other, you might actually argue that while on the ketogenic diet, the FLAIR abnormality, the brightness that you see on the right, actually may be a little bit worse. It maybe is a little bit progressed. And this patient, unfortunately, did pass away fairly recently, actually. This patient, a 37-year-old casting director, she runs her own casting agency. I've never seen a person so active in my life. She has a low-grade spinal cord glioma that's grown through radiation therapy and chemotherapy. You can see that expansile mass on the sagittal view of the thoracic spine over on the left prior to the ketogenic diet. And on the right, while on the ketogenic diet, you get the sense that it's less expansile. It does look slightly smaller. Again, are there other factors at play here? There certainly could be. Every time you do an MRI scan, the slices can line up slightly differently from one scan to the next. Maybe that has something to do with it. But when I look across all the scans, it does really look like there has been an effect. I would say clinically, from a functional perspective, before going on this diet, she was having leg weakness. Her leg was intermittently buckling from her. And after she went on the diet, she was back to kind of running around full speed, 100%. This is a post-contrast image of that same patient. Pre-diet, you can see on the left that maybe there's that little speck of contrast enhancement. When we see contrast enhancement, we're worried potentially about aggressive tumor. And on the right, again, you don't see that so obviously. Again, for whatever reason, you don't see it. This patient here is a patient who was recently diagnosed with a low-grade, a grade 2 oligodendroglioma. And you can see, again, the difference between the scan from the left before the diet and the scan on the right while on the diet. Again, is all of this an anti-tumor response? I would argue that some of it is probably an anti-edema response. I do think that one of the effects of the ketogenic diet is that it does reduce cerebral edema. But again, you can certainly just visually see the difference between those two. This patient, another patient with glioblastoma, you can see again on the left, you see that contrast enhancement around the resection cavity, and on the right, again, it's not so obvious. It's not clear, again, if this contrast enhancement that was present on the left, if that is truly tumor or not. It certainly could represent some reactive process as well. That's possible, but it's certainly less notable on the ketogenic diet. So a biostatistician would look at everything I just presented and still say, you know what, you haven't proven anything. And that is absolutely true. This is not a clinical trial. I cannot say anything from what I've just showed you that is definitively proven. On the other hand, what we do have are stories, and these aren't just made-up stories, these are real stories. And what I will say, and the other people who have dealt with these patients will say, is it's been truly remarkable to see the impact of this intervention on patients. We had one patient who, prior to starting the ketogenic diet, because of the tumor, was no longer able to read. He had alexia. Not long into the ketogenic diet, actually just a couple of weeks in, he was able to read again. That's a pretty objective thing. You can't really fake that. So that's a pretty substantial improvement in quality of life, from going from not being able to read to being able to read. I have another patient who prior to starting, a glioblastoma patient whose short-term memory before starting this was atrocious. He was basically living day to day, just kind of going through his routine. Now he basically feels back to his old self. He's back on Tinder and trying to find dates. So again, a substantial difference in terms of quality of life. You can even look at that patient, the 27-year-old glioblastoma patient who passed away. Yes, he passed away. Ultimately, he died. That is true. But before he died, he had an amazing response when we first initiated the therapy. I had been following him, again, since diagnosis, and the clinic visits used to be this thing where he would come in, he would always be very impeccably dressed, and we'd spend most of the visit talking about books or philosophy. But in the months preceding this dietary intervention, he was really going downhill. He came in basically sloppily dressed in flip-flops, he was hemiparetic. We weren't having those sorts of conversations anymore. 2 weeks after we started the diet, he was back to himself. He was sharply dressed, we talked about books and philosophy, and he spent the summer being able to go to 2 family weddings. When he passed away, I had a long talk with his mother, and one of the things that she said is that they were so grateful, he was so grateful, they were all so grateful that he had that summer where he was able to be himself, to be able to be with his loved ones. And so even in a case like that, where at the end of the day, it's a glioblastoma patient who died, I do think that even in a case like that, you can make an argument that there's been a tremendous impact here. Even still, what do we want? Evidence-based science. When do we want it? After peer review. And so with the sponsorship of the Epigenix Foundation, we are embarking on a phase 1 clinical trial of a 6-month calorie-controlled ketogenic diet in combination with standard of care for patients with newly diagnosed glioblastoma. One of the unique features of this clinical trial is that there's actually a fairly large enrollment window of a few months. And the reason we wanted to do that is because oftentimes when patients are diagnosed with glioblastoma, they're diagnosed at a local hospital. They don't know what all the different treatment options are. Oftentimes they'll start treatment locally, and then they'll be interested to see what their potential clinical trial options are. With this design, what we'll be able to do is to take patients within a 3-month range from their initial diagnosis and put them on a 6-month calorie-controlled ketogenic diet. We're going to monitor everything. This is going to be an incredibly data-rich study. We are going to, of course, look at all the laboratory parameters. We are going to look at ketone and glucose measurements, of course. We're also going to look at things like quality of life. We're going to look at cognitive status. Again, a lot of the interest in that has come from our experience with the patients that we've managed so far. We'll be looking at clinical efficacy, we'll be looking at metabolic efficacy, and there's a whole host of exploratory biomarkers that we'll be looking at as well. That's one of the things that coming to a conference like this just makes so much more interesting, just to hear about all the potential different things that we can be looking at in this patient population. To summarize again, I can't look at anything that I've said and say, okay, we've proven anything at this point in time. But what I can say is, one of the misconceptions of a neuro-oncology clinic, everyone thinks that it must be the saddest and most depressing place to work. And in truth, it's actually the opposite. It's very life-affirming. I certainly have had my share of sad and tough conversations with patients and families, but at the end of the day, we're all going to die. We're all going to die, and what these people have to do every single day is wake up and confront that mortality one way or another. There is so much interest in the brain tumor community and in the cancer community to be able to do something that they can control. There is so much interest in a dietary intervention. At the end of the day, again, I don't know how this clinical trial or any other clinical trial is going to turn out, but I'm certainly interested to come back to this conference in a year or two. Thank you.
Good afternoon. Well, my journey to get here in front of you guys was not really because of my background in outcomes research, which I have had for 20 years, but rather it was because my brother is Ron Penna, and so he had kind of brought me into the Epigenix Foundation to oversee some of these clinical protocols. So I guess you could say I am the Ivanka Trump of the Epigenix Foundation, although a lot shorter and less glamorous. So as Dr. Hu said, as we were thinking about bringing it, well, I guess let me start back from last year. As Dr. Kesl summarized, we did a little safety study with patients in Louisiana, just as we started getting our feet wet with doing some clinical research, taking it from the dogs and translating it into the humans. And then we sort of split that patient experience into two tracks. One that you heard from Dr. Hu with the late stage patients for whom standard of care has really been exhausted. And then we also wanted to go to the other end of the spectrum and say, well, could we intervene with a metabolic therapy in people who had a cancer that was detected very early on? So that was our idea, but then we had to figure out a way, well, how are we going to find such a cancer that's detected early on? And over the last 20 years, people have been focused on genetic markers to identify cancer and look for early detection. And I think in the last several years, companies and researchers have been moving away from the genetics and looking at the transcription of the genes and then the translation into proteins. So we looked at a number of different companies who have mRNA tracers and protein tracers to try to identify cancer in its earliest forms. And there are a lot of companies in that space. But then, as you go and try to dig in and try to use one of those cancer markers, a lot of them really aren't ready for prime time. So at the end of our due diligence in trying to find this cancer prediction molecule, we came across a company called Oncoblot in Indiana, and they had a blood test that could detect tiny amounts of a membrane-bound protein that gets shed into the blood called ENOX2. And this protein is only found in people that have cancer and is not found in non-cancer people. So if you take, say, a mammogram, you need a 10 to 20 millimeter size to detect a breast cancer. And Oncoblot can detect it when it's less than 2 million cells, or roughly about 2 million cells. So a much, much smaller tumor that you could never detect on any kind of clinical imaging. So when we first started looking into it, this is what the Oncoblot test looks like. And we did a bunch of these in our friends, family, extended contacts. So the one on the right there is a colorectal cancer. So it comes back and tells you at the top whether you have the ENOX protein in the blood, yes, no. And then it can also identify over 20 isoforms, which are different tumors, and it can tell you a specific, which tumor that ENOX protein represents. So we had some colleagues who had cancer and had had the tumor resected, and indeed their Oncoblots came back negative. We had some colleagues who had, say, breast cancer that was on a mammogram. The ENOX was positive. They had a lumpectomy, and then the Oncoblot came back negative. So we sort of kicked the tires with it over several months. And in colleagues and family members that had cancer, the Oncoblot always came back with the specific cancer that they had. So we didn't really see any discrepant results. And we said, okay, well, let's try using this early detection marker. So then we had to try to find an oncologist that was willing to explore this with us. So we found Dr. Elliott and Dr. Baucom in Baton Rouge. They're both surgical oncologists whose specialty is breast cancer. Dr. Elliott has had a practice for over 40 years in the same place. So they have a long-term, very huge population, and they have a lot of high-risk women who are at very high risk for breast cancer. So I met Dr. Elliott through Dom D'Agostino. He had put us together. And it took, over several months, we kind of fleshed out this idea, and they said, let's try this in our patient population. So they pulled together a number of women that they felt were at their highest risk, so that we were hoping we weren't going to have to do too many Oncoblots in order to find a positive population. So what we did is we took these women who either had a first-degree relative or were BRCA positive, had some atypical findings on breast biopsy, or had an abnormal mammogram, but none of them had actual frank malignancy detected. So what we had told the women when they came in is that if you sign up to do this Oncoblot test, if you're positive, we're going to have you do a metabolic therapy, which will involve first going on a low carbohydrate diet for a couple of weeks, and then for 120 days you're going to get these meals delivered to your house, which are a 2-to-1 ketogenic diet, and they're going to be sort of individually focused to you with some additions and things because people had different caloric needs. We're going to give them some supplements, put them on an exercise program with an exercise monitor that they had to upload the pictures of their heart rate 4 times a week. And then they had to collect and give us their data through an app that they had on their phone. So twice daily glucose and ketones, a daily weight, and they had to upload body photos in sports bra and shorts so that we could kind of keep track of their body composition and then do a weekly phone-in. So it was a really intense program that they were embarking on. But they have such this amazing relationship with these two surgical oncologists. We got actually a lot of people that said, yeah, I'll sign on to that. So we did 37 oncoblot tests, and of those in that very high-risk population, 26 were positive, which is a pretty big positive rate. And initially we were like, wow, that's a lot. But none of the positive oncoblots came back colorectal or even ovarian. I mean, they all returned with a positive breast cancer diagnosis in this high-risk breast cancer population. And of the 26 positive, 24 said that they would participate. We had 5 people drop out through the course of the 120 days. One didn't have, the diet didn't agree with her. One got a kidney stone early on and had had a kidney stone before and just did not want to continue. We had a couple that were not compliant with the data collection, and then they just eventually dropped out. And then we had one whose cardiologist said, I really don't want to keep her on this high-fat diet. Her LDL's going up. I'm going to pull her from it. What I'm going to tell you about now is just still some preliminary results, because some people are still finishing up the study and we don't have final results on any, on every single person. But I'm just going to give you a little bit of preliminary peek. So the glucose measurements, we had 93% compliance with the data collection, which when you think about that, that's pretty amazing. 120 days, twice a day data collection with the weights, the monitors, et cetera, and 93% compliance with all of the data elements. Their blood glucose daily average was about 93, and their average daily ketones were 2.4. So, they were compliant, they stuck to the diet. From the time that they started the Atkins-style low-carb all the way through the 120-day 2-to-1 diet, they lost a total of 300 pounds between the 20 women, which is pretty impressive. So if we had been running this as a weight loss program, this would be really impressive results. But this was, again, an isocaloric diet. We were not trying to lower their diet, to lower their calories. And then in terms of the oncoblot, everyone except for 2 people went down on the amount of protein that they saw over baseline. So the dotted line is the threshold that the company calls a positive test versus a negative test. So, am I saying that we totally, got them from positive to negative? No, absolutely not. But preliminarily, it looks like, we had 2 that did go negative, but there's a standard deviation of plus or minus 3. So I can't say for definitively, yes, they all went down, but it's looking that way. What we're going to do once we get everyone through the program, we're then going to do this in triplicate, where we can get a better sense of, the standard deviation will be a little bit tighter, and we'll know more definitively whether, how robust this finding is of them going down. We're also going back and taking oncoblots on the women that dropped out and the 2 women that didn't participate, and see if the trend in those people is different from this. And then just the one last thing I want to mention on the data is, because it's come up a few times at this conference, is we did see a significant rise in non-HDL cholesterol in a lot of the women. Now, I know there's been a lot of, presentations about how this probably doesn't really matter, et cetera, and we did see the triglycerides drop significantly, the HDLs rise. Now, we tried, after we saw these, the LDLs going up, we did try to switch the fat source and do more monos and swap out the saturated fat. And we're still following up these women with follow-up labs, so I can't tell you exactly what's going to happen after that switch. All right, so with that, I'm going to let Dr. John Sledge tell you where we're going to go from here.
Thank you. Thank you, everyone, for staying late on this Friday. My route here is slightly more circuitous than even the ones you've heard about. So, but what my job has basically been is, I'm an MD. I do metabolic research. I'm an orthopedic surgeon. I sort of get to ride shotgun and try to figure out what's real, what's not real, where do we go, where do we not go. Mostly, basically, we just try to guide Ron Penna's brilliance into where it might be best used, because he's the only one I know of right now who's actually funding some of this early work that needs to get done to generate the background data so that we can get the NIH funding and we can get the organizations and the institutions to actually fund some of the research. So some of the translational research you just saw from Dr. Hu, where they now actually have the proof of concept so they can actually present it to an oncology group to actually get some formal funding. It's really hard to do those first couple of steps because with metabolic research, there's nobody who wants to fund it at the clinical level. because there's nobody who's got a return on their investment for funding that initial research. So we're now seeing 2 projects move from concept into dogs, from the dog validation into humans, and now looking at 2 cancer portfolios, one in the very late stage and one in the early stage before their standard of care. And what I think we're hoping to see is those bleed now into the large volume of patients that have cancer, that have standard of care, where this can be used as an adjunct. So where do we go in 2017 with the Epigenix Foundation? We know from the dog data and a lot of the work that Bob D'Agostino and Tom Siegfried has done that 25% of the dogs still went on to die from cancer. So we're slowing the growth, we're stopping the growth, particularly we're limiting metastases, but we still have a fairly significant rate of mortality. So the take home for us is that the diet alone is probably not going to be enough in the majority of patients who have late stage disease to eliminate the tumor. We know you have to have a Warburg effect for the diet to have significant effect. There are some secondary mechanisms, but the majority of it's through energy metabolism. What sort of role would that have on early tumors before they're able to develop a significant Warburg effect is one of the other things we're going to look at. From women, we know that the diet decreases the cancer marker, but it doesn't seem to drive most of them to zero. Once again, the diet is probably going to be effective in an adjunct role, probably not as a primary role in terms of tumor genesis. The ketogenic diet's role will probably be supplemental in treatment. So we've broken this up into the 2 groups that you've heard some early work with already. One is in the early tumors and the late tumors. The 2 things we're trying to look at now is the Warburg effect. How well does that correlate with the efficacy of a ketogenic diet? The other is how does the microenvironment around the tumor affect both implementation of diet and secondary means of addressing tumor growth? So we're looking a little bit more carefully than we have at cancer physiology and in particular the cancer immunology. The ketogenic effects on the immunological manifestations in the local environment of tumors is sort of an area where everyone is starting to delve into a little bit more as the immunology of cancer becomes more important, as the genetics of cancer become less important. So the questions are, what other treatment options are available during the early preclinical window where there is no standard of care? So early interventional treatment options, where before with standard treatment, particularly late stage, what you do is you maximize your treatment until you reach thresholds of complications that you're not willing to tolerate. So if you look at the doses of chemotherapeutic agents they give, they're not giving higher doses because they've already killed all the tumor. They can't give higher doses because of the systemic side effects that they're going to see. Where when you're treating preclinical disease, you actually have to choose interventions that don't have side effects because since the patients are asymptomatic at this point, to invoke a treatment that causes them significant side effects, what's worse, the disease or the treatment? So we're looking for interventions that have minimal or no side effects, but hopefully maximal tumor effect. We know we're going to need to use a multimodality approach. You heard an excellent lecture beforehand that's got to be multimodality. You've got to have this press pulse type phenomenon to basically get the maximal tumor effect. So we're hoping to address 3 specific areas of tumor growth, one being energy metabolism, second being cellular division, and the third being the immunological susceptibility of tumors in different states depending upon the tumor microenvironment. So some of the compounds that we're looking at already, I know these have been touched on already by some people. What we've done is working with people, first looking at benchtop feasibility and small animal feasibility. There are individual substances such as capsaicin, you'll see on the left, which is out of a pepper, the EGC, which is out of green tea. The one on the left shows what happens to cellular proliferation of a normal mammalian cell, a mammary cell, versus an adenocarcinoma. And you can see, if I can get you can see significant decline in cell volume here compared to the normal mammillary cells. So they seem to have an effect on the tumor cells, but do not have an effect on the non-tumor cells. Same thing here with the ECG. Once you see normal cell NAD oxidase, which is energy transfer here, you see a marked decrease in it in those cells that show cancerous characteristics. This is work done by Dr. Elliott, who we're working with on the breast cancer study. This shows basically the Kaplan-Meier curves that we've been looking at for the last couple of days. Here's standard breast cancer. Here's breast cancer where we've been able to boost their immune system. And this is endogenous immunity, so we're actually using the patient's own immune cells to try to revitalize them to address the tumor and also to alter the microenvironment around the tumor to make it more accessible to the immune system. So in laying out our plan for the Science of Progress in 2017, we're trying to strike the balance. There's a balance between rapid advancement and responsible progress. So we want to make sure that we can move these important advances that the basic scientists are making, both at the benchtop and in the laboratory with the small animals, and try to move those into the clinical setting as soon as we can, those that show promise, but not so fast that we're missing side effects or we're getting unintended consequences. We want to validate an early detection method with quantification. I think this is probably going to be one of the more important things we'll do, because now instead of looking at secondary surrogate markets, I felt better, maybe their OS or the overall survivor was slightly longer. We can actually look at tumor burden and tumor bulk if we can find some means of quantifying tumor load. We want to determine what the best biological markers are, because then we can use those as tumor progression markers to assess disease progression. It'll be a way for us to assess interventions, including dietary and metabolic manipulations. We also want to be able to use biomarkers to measure the effect of patients with individual and combined interventions, because it's really hard if you're looking for overall survival. You're waiting a long time to find out what the intervention is. Where if we can validate biomarkers in an animal model, translate those into the human model, we can then put patients through a series of interventions and very quickly with biomarkers determine the overall efficacy or combined efficacy of the different treatment modes. And the last thing we've already started and we're moving forward with is to create a collaborative working group so that the data and the progress can be shared and so we can disseminate the information faster. So personally for me, I don't have to wait a year to get here to find some of the other speakers, the advancements they've made in the last year. There'll be some sort of network we can use so those advancements can get out to those of us in the field a little bit faster. I've got just a few other things I want to cover. One is the acknowledgments. There's a long list of people who've participated in this project. Literally, I think if you look to the person to your left or the person to your right, at least one of those people have helped us participate either in the conference, the progress, the research over the course of the last 3 years. Obviously, the biggest thank goes out to the Epigenix Foundation and the wonderful work they've done in supporting both the clinical research we've done and the translational research and hosting the conference.